Good morning, everybody, and I'm so very sorry that we couldn't meet in person. My name is Borjesson. I'm a professor of sports physiology and a cardiologist from Gothenburg in Sweden. And what I will do is turn my phone off now when I talk to you, so I don't have any interruptions. Let's do like that. And my talk today is about health benefits of physical activity in cancer patients. But I do want to start about the effects of physical activity in general. I'm the director of the Center for Health and Performance in Gothenburg. It's a laboratory, you can see it on the down right-hand corner. And it's where we perform studies on physical activity for health and also for performance. Mainly we do both actually, and we do a lot of effects on physical activity for health. So my schedule today is to talk about physical activity and health in general, and are we active enough, and also health effects when it comes to cancer patients specifically, and cancer in general, and also for prostate cancer, and also talk a little bit of the methods to increase physical activity, because that could be the crunch. So first of all, I'd like to remind you that lifestyle behavior is for real now, and you all know that when it comes to the COVID. This is a newspaper clip, unfortunately in Swedish, but you will understand that it says physical activity strengthens the health. And what I want to tell you about this is that we all are involved in this discussion, I think both in Holland and in Sweden, about the risk factors having a matter in who will be seriously ill and who will have need for respirators and so on. And also physical activity and lifestyle behavior will have a great effect on the rehabilitation process and the need for physical activity. For muscular training and aerobic training and so on. And also, of course, for our defense for the next COVID infection. Overall, lifestyle behavior contributes large to our total health. And this is a figure some years ago from Center for Disease Control in the US, where it was approximated that lifestyle behavior caused around 50% of our total health. And possibly that's even more now. But this is really important to think when we spend a lot of money of access to medical care and also interested in both environment and genetics, that lifestyle behavior is a big reason for our total health. And when it comes to physical activity, which is one of the major lifestyle factors, it's of course has multiple effects, showing here on the cardiovascular system, which is where I come from. When you have the decreased risk of diabetes, increased aerobic capacity, you have less risk of hypertension and treatment of lipid disorders, inflammation, vascular function, and so on. But also in the right-hand corner here, you can see effects on lots of other organs, like the bone structure for osteoporosis, arthrosis, quality of life, fatigue, depression, and anxiety, for instance. So we have a lot of multiple effects, of course, of physical activity. And this is collected in our country in a book called the Swedish Phys Book. And I'm not showing this because it's only in Swedish and you can't get hold of this. On the contrary, you can see on the address down below, you can see the address there, www.phys.se, where the Phys Book in the English version is all available. All 650 pages of it, it's available in English. And in this book, it's collected the effects of physical activity on different diseases. The last version had 39 different entities, all the way from arthrosis to depression and heart disease. And it collects the evidence similar to what you do with the effects of medications, mode of action, the dosage, type of activity, is better for arthrosis and so on, the intensity, the frequency. What is the evidence for this? And any side effects and contraindications and so on. So it's very similar to the book on pharmaceutics, and this is the collection of evidence for the effects of physical activity. And then comes the next question. We know it's good for many diseases, and then are we active enough then, and how active should we be? And again, this is showing in the national recommendations on physical activity in our country, but this is on purpose because it's the same all over the world. They are global and they're very similar. Either it's the WHO or the Swedish or the Dutch or the US recommendations, and also from different medical organizations. We talk mainly about medium intensity activity, 150 minutes per week as a goal for the general population. And preferably this would be 5 times a week, so 30 minutes 5 times a week. But the total minutes is the one which is emphasized in the latest WHO guidelines coming out just recently. So this is the goal, at least this. But how active are we? This is the Eurobarometer 2014, and I just marked 2 countries here, and by coincidence, it's the Netherlands and Sweden. And you can see on a question, the inhabitants in our countries, when asked about do you exercise or play sports, the answer was never. And it was 29% in Netherlands who said never. So 71% were active in exercise or play sports. This is all ages, like 20 to 85 or something. And in Sweden, 91% said they were exercising and playing sports. Well, these figures are not true. I mean, this is greatly exaggerated. And this is how you get when you ask people. And I'm not saying people are lying. I'm saying it's difficult to know how active you are also. So I think we need other measurements. In our lab, we use something called the accelerometer. And this is a slide taken from a recent review article on this method of using accelerometer, which is a more objective method on physical activity. You put the accelerometer on your hip, on your wrist, or on your thigh, as shown to the left. And then from that, you get raw data on all accelerations. And then from that, you can do raw acceleration data processing and also calibration. And from that, you can get statistics showing that if you spend a certain amount of activity in sitting, low intensity activity, medium intensity, high intensity, and so on. And then you can group that into different times of the 24 hours, etc. Well, when we do that, we use that in the Swedish SCAPI study, which is enormous epidemiological cross-sectional study on 30,000 Swedish people in the middle age between 50 and 65. This trial this study is ongoing, and the data is all collected though. But this is from the pilot. It was the first 1,100 from Gothenburg. And as you can see here, this is a pie chart of the activity during the day. And you can see here that in the men to the left and the women to the right, that the most part of the waking hours, which is here customized to 16 hours, you can see that 9 to 10 hours is spent sitting. So 9 to 10 of our waking hours is spent sitting or sedentary. That could also be laying down, of course. And then the rest of the day is actually spent what we call in low intensity activity, LIPA. That's about 5 to 6 hours. And then if you put medium intensity, that's the health enhancing activity, and also a vigorous activity, which is also counting that. You have to put them together to reach 3 to 4% of the waking hours. And that also makes it that how many people then fulfill the recommendations of 30 minutes of this MBPA per day for 5 days a week. And that's about 1 in 3. So this is a vastly different figure than officially reported. When you do in self-reports, that says about 2 out of 3. or even more in the Eurobarometer. That's 70 to 90% of people said they were active exercising. So this is a more reliable figure, I would say. 1 out of 3 is physically active enough. And also another point is that fitness, and this is important to study here within 266,000 adults to see that the fitness and all-cause mortality, as you can see, as the fitness goes up, the risk of mortality goes down up until 60 milliliters. Above that, we shouldn't look at the figures because it's too few people. So forget that. But you can see on the left side that the ones with the lowest fitness, they gain most by just increasing their activity a little bit. And this is, of course, very important when it comes to urological and cancer patients especially. They may have very low activity if you're a cancer patient. Again, sedentary time is not, again, I mean, we talked about physical activity, movement and fulfillment, and then fitness, the importance of fitness. And then comes sedentary time, which is very popular now. People say, oh, you don't have to train, you only need not to sit. At least that's the message sometimes conveyed in podcasts, etc. in our country. But to look here, importantly, the people who are low fitness, called inactive here to the left, the more you sit, the greater the risk. But you see, if you're active and have a higher fitness on the right, the risk is much less. With each quartile or more sitting, then the risk is not so increasing so much. And if you had an even more active population, like the Dutch national team or something, they would be even far to the right, and then it would probably be a flat from the most people sitting most and sitting less. The risk would not increase. So if you do high intensity activity or medium intensity at a high or medium to high intensity 1 hour a day and above that, you have a much less risk of sitting. But again, many of the patients we see have a low fitness, are physically inactive, and then it matters a lot if you sit. So when we go into cancer then, having established the role of physical activity, sitting less, good fitness, and so on for general health, it's described in the FIS book and elsewhere that yes, prevention, physical activity, regular physical activity reduces the risk of developing certain cancer forms, at least, like breast cancer, colon cancer, and endometrial cancers. So the general recommendations on physical activity of health can be applied. So we can strive for 30 minutes a day of medium intensity aerobic exercise every day as a starting point. And of course, if 1 out of 3 of the normal population don't reach this, it's a great chance that many of these patients, even more percentage of these patients will not reach the normal recommendations by the WHO. And it's also implicated that you also use other lifestyle modifications, and also in the palliative phase. So this is what's stated on the basis of evidence. Looking more specifically into surgery and to cancer, starting with preoperative physical activity level. So if we ask people their normal physical activity level, it will be associated to both postoperative recovery and to complications. That meaning that if you state that you are regularly inactive, you will have longer recovery and more complications. And this has been studied in several studies by our group, our PhD student Aaron Onerup. And as you can see here, it's both in breast cancer, and this is also colorectal cancer, and also we've done it in gallbladder surgery, etc. So yes, preoperative physical activity level is something you should ask for because it will give you an indication on the recovery and complications. When it comes to cancer in general, looking at the Cochrane reviews, it is like for exercise interventions, has a good effect on health-related quality of life in these patients during cancer treatment. And this specifically, as highlighted in yellow, will improve the overall quality of life, also the person's physical ability and the way the person functions in society, and also to reduce tiredness and fatigue during the program, which is very important information. So we got real support for the use of exercise intervention during cancer treatment. And which are the mechanisms for the effect on physical activity for general health? We know, right? But in cancer specifically. Well, this was highlighted very nicely in a recent review here in breast cancer by Dr. Sil Hong and et al. And as you can see here, the potential effects of physical activity involves a lot of mechanisms. I mean, the immune system will be affected and possibly improved. Hormone levels is certainly affected, and this will affect the disease stages, especially in hormone-dependent cancers like prostate or breast. And vascular effects, of course, or anti-inflammatory effects. And weight control is also important. As you can see here, we have so many effects of interleukins on tumor necrosis factors, CRP, the sex steroid hormones, etc. So there's a lot of potential effects where physical activity might help in the combat against cancer. What about prehabilitation? What about if it's so good, what couldn't we optimize the patient before, like an athlete preparing for the Olympics? Could we optimize before surgery? And in that way, as the figure shows here, maybe before the surgery, get a greater independence, and when we reduce our capabilities and functions after surgery, that we have a slower upstroke, so to speak, and that we have a enhanced recovery and less complications. And also, could this affect survival? And this has been more and more popular with prehabilitation, that you train before the cancer. Of course, could be difficult because some cancer forms are so malignant you have to operate directly. But in some other forms, you may have sufficient time to do something. Is it effective? Looking at lung cancer surgery, this study here by Stephens et al. Shows that yes, exercise seems to, this was a meta-analysis from a number of studies, that you can see here that the hospital length of stay seems to be shorter in the exercise prehabilitation, and also the number of preoperative complications seems to be lower. And so in lung cancer surgery, definitely it has a place. And it also has to do with the treatment or training of respiratory muscles and complications from the lung. What about other surgery? This is major abdominal surgery and colorectal cancer surgery. As you can see here in this study by Barbero and Garcia, it has tremendous results of doing 6 weeks of supervised preoperative exercise. As you can see, there's less ileus, less cardiovascular complications and overall complications. The hospital stay are lower, especially the days in ICU, etc. So in this study has great effects. In uro-oncology or surgery, it's summarized here by a study, recent narrative review that says that if you combine physical activity, nutritional and psychosocial targets and interventions, then it has to be shown to be effective, so-called multimodal approaches, and better than doing one lifestyle factor on its own. What about after in cancer survivors then? What about exercise interventions there? Well, this is also taken from the Cochrane. There's 40 studies on that. And again, it seems to suggest that physical activity and exercise programs will have improve quality of life after exercise programs. And that means that the persons have less worry about the cancer, has better views, so to speak, or on his or her body, and dealing with emotions, and of course anxiety, tiredness, and also some effects on pain. And this is also showing that, yes, according to the Cochrane systematic reviews, we can have effect also after the cancer treatment. So in summary, going back to the FIS again, that individuals with cancer should be recommended aerobic and muscle strengthening activity. And the reasons for that is that we might increase survival in breast, colorectal, and prostate cancer. And this is 2-star evidence out of 4. Decrease cancer-related fatigue, which is even 3 out of 4. Improve quality of life, 3 out of 4. Increase aerobic fitness, and increase muscle strength. And this is something you will need in a recovery phase. So we have a lot of reasons to use physical activity in cancer. And again, we can use the normal levels of physical activity, 150 minutes a week, and so on, and also combine that with muscle strength and activity, which is also part of the global recommendations, I would say. What about high intensity activity then? Is it even better? No, it doesn't seem that way. High intensity interval training is very popular, but when it comes to in cancer patients, it has similar effects to medium intensity activity. And of course, that's much easier to administrate, at least in most cases, especially if you have worries about going too hard. But the medium intensity activity has the same effects. Both are superior to usual care. Again, when it comes to physical activity in cancer, it should be individually tailored. There's some things you have to think about. Of course, that differs from different cancers. Ongoing infection, which is common, is an absolute contraindication, and you should strive for moderate, at least, activity, vigorous if possible. And of course, you should also be wary 24 hours after a chemotherapy infusion. So ending up with the prostate cancer, I would say the specific goals in prostate cancer is to improve quality of life, general health, improve survival and outcome, and mitigate the adverse effects from ADT treatment. And this is really interesting. First of all, the survival. There are a couple of studies, and I'll just show you one. And this is 2 slides I got here from Dr. Östergren from Copenhagen, and he gladly shared it with me. And here you can see the mortality and overall mortality and prostate cancer specific mortality is lower in this Canadian cohort of men with prostate cancer, followed up to 17 years. And so survival in this study, and also at least another big study, shown that it could have effect. Very interestingly, the adverse effects of androgen deprivation therapy, as you know that this treatment will increase fat mass, decrease muscle strength, increase insulin resistance, increase lipid levels, and decrease bone mineral density, and decrease quality of life. All these are typical targets for physical activity, which has the reverse effect of all these effects of the ADT treatment. So as soon as you give somebody ADT treatment, you should also give them physical activity to mitigate all these side effects. And this is really important because this has been largely forgotten, I would say. And in a review, you can see that, yes, exercise for men with prostate cancer in 16 randomized control studies, 1,600 patients almost, and at least 8 weeks treatment up to 1 year. Yes, you improve the cancer-specific quality of life, reduces fatigue, and increase and improve muscle strength. And therefore, the EAU guidelines for prostate cancer undergoing ADT treatment do recommend, as highlighted here in red, that if you are androgen deprivation therapy, you should be, you are recommended 12 weeks of supervised combined aerobic and resistant exercise, and by trained exercise specialists, and possibly in a group setting, because that has even greater effect. So I added that, and this is the rating of this is strong. However, if you look at the recommendations, when somebody read a very interesting review recently, looking at the 69 guidelines that on rehabilitation with cancer, 37 of those recommended physical activity as part of rehabilitation, but very few of those provided that. That difficult types of cancer and so on, but the clinical effects and the findings of this is that very few use this. They have it in the recommendations, but it's not also used, and this is very interesting. So there's low utilization of this. And why is that? We looked at, this was in the thoracic department of the Karolinska Hospital in Stockholm, one of my PhD students. We looked at the gap between the stated importance from the healthcare professionals, what they thought was interesting and important, and what they in fact did. As you can see here, all the lifestyle factors, working with those were very important in general, very important in own practice, but very few of them did ask, and even fewer did counsel to a great extent of the lifestyle behavior change. They were complaining about clear routines, clear goal setting, and less of support from the management. But I will also add the motivation of ourselves. The motivation of the patient is a problem, but what about our own motivation, our own willingness to do this? There is a gap between what we say and what we do. And then I think we can use systems. We need systems or models to increase the activity in patients with insufficient activity in healthcare. And the Swedish physical activity on prescription method was through a systematic review last year, and this method consists of person-centered dialogue, individualized prescription of physical activity, and a structured follow-up. And in this dialogue, in person-centered dialogue, where the patient and the doctor will discuss the barriers and enablers for activity, motivation, other diseases, and you know the ideal prescription according to the FYS has to be adjusted and individualized and then followed up. And this systematic review also showed that the evidence for this method to increase physical activity was high. And therefore, the European Union said that the Swedish physical activity and prescription method is best practice. And we have an ongoing 3-year European Union project where 9 European countries take part. Unfortunately, not Netherlands, but Belgium is part. And they have come to Sweden twice to have education in Gothenburg. But the third time we had to use it digitally now in October. And this from this project comes implementation tools, an English translation of a short FYS, and evaluation, etc. So this is one method you can use to increase the physical activity on those insufficiently active, especially after the rehab process, be it heart, cardiac rehab, or after urological or cancer or prostate surgery. So let me finish that up and thank you for the offer to talk to you. And I would love to have visited the beautiful country of Netherlands. And in the meantime, you have to suffice with one slide from the Gothenburg harbor. Thank you very much.
Questions? Yes.
Thank you for this nice presentation. My name is Joe Voormans. I'm a urologist from residency in Rotterdam. And I wondered what's your opinion, suppose we take prostate cancer, which is in general slow-growing cancer. At what time of the disease do you think this physical exercise would make most difference to the patients or the most benefit? Would it be in a preventive setting, or when the patient is diagnosed and is scheduled for curative treatment, or is it after he received curative treatment?
I think the strongest evidence today is that we use it in the on patients which are anti-ADT treatment, so to speak, and because they will have a great risk, and if, in fact, some of the studies show that the risk of cardiac complications in this group is even bigger than the risk of the disease itself in the coming years. So I would target this group very well, and I would say after the treatment is initiated, you should have shown by great examples in Denmark, for instance, by Professor Östergren's group and Dr. Östergren's group, that you can train for at least 8 to 12 weeks when you have received ADT treatment. And I think that's the strongest evidence and the best way, the model of doing it. Of course, physical activity also before surgery is important. The problem is a little bit that we don't know. And prehabilitation is very advocated, but looking at our study we did in colon cancer, we did not get any results in a randomized control study, which I think is because we did too little activity for too little time, perhaps. We don't know. So I would say the safest bet today is to do in the rehabilitation phase.
Hi, Androgen, medical oncologist from the Netherlands Cancer Institute. Thank you so much for your wonderful presentation. You convinced us even more that we have to advise our patients to exercise, and also ourselves, we should exercise ourselves. Wonderful presentation again. Many pictures of running people, people lifting weights, and at times I think prostate cancer patients who are late in their 70s, early 80s. All the testosterone has been taken away from them. They take opioids, feel pain, and what do you advise me to advise them? What should they do? I mean, usually, like, what do you do all day? Well, we stay in bed for a long time, go to sleep in the afternoon, and for the rest, sit on the couch. So what is reasonable to advise those patients in general?
You know, the sound is not very good, so I'm not sure I got the whole question. But if you're talking about strength training and these patients with possibly vulnerable, you know, the skeleton and bone structures, I would say, of course, you have to have help with specialized physiotherapists so you don't do it too much, right, with the weight bearing activities. But in general, I would say that the nice thing about this is that we strive for the recommendations. The general recommendations for the normal population is the goal. So of course, all these things that we all have to do to try to reach these 30 minutes of medium intensity activity, that's what I would really try to emphasize. And lighter, you know, strength training on top of that for preventing falls and so on. And I would also like to remind you that and point out that medium intensity activity in somebody who has a low capacity, it might mean, you know, walking. So I think that's, so my general advice, if I thought that was you asked for, is to strive for the 30 minutes a day activities. And that doesn't have to be very much if you are inactive before. So you have to, individualize that. I hope I answered your question.
Ja, het Willemsen Museum Utrecht. U schreef in het beginning that the hours of physical activity in the general population is overstated. People tend to exaggerate. And on that basis, all the older epidemiological studies on cardiovascular risk reduction in the general population based on questionnaires, don't you think that the amount of exercise needed to reduce the risk, the health risk in the general population might be over exaggerated then as well?
Yeah, if you're saying that the recommendations are built on self-report, right?
Yeah.
Yeah, and I agree totally. So if most of the recommendations are built on self-report, that means that yes, there is probably a bit of exaggeration. And we know for certain that even if you spend less activity than 30 minutes a day, as measured by accelerometer, for instance, more objective methods, you will gain, great health effects. So I agree with you, and we have to wait until the new methods have been used to create possibly, adjusted guidelines or recommendations on activity. So you're right.
Most is me, Ronald. I think the most convincing slide that you had was the Canadian study with reduced prostate cancer mortality in patients who did the regular exercise. But are there any contemporary data, or is there ongoing research for T-cell function? Because the most obvious explanation for a relationship between physical energy and cancer mortality would be immune competence. I think that is the most logical explanation. So you want to research on immunocompetence like T-cell function. The immunological markers for being able to fight cancer or to contain it.
Yeah. Again, the sound is very difficult for me, but I think you said that the mortality and the prostate cancer, and I showed you one study, the Canadian study, but there are more studies showing the same, and I agree with you that this of course is the ultimate goal, and I also think that you said that it's the immune function, you think it's the effect, and I agree with you, but when it comes to ADT treated patients, which are a growing group of men who survives longer, we will have a group which is extremely high risk for cardiovascular complications, and the risk of cardiovascular complications might be even higher than dying from the actual prostate disease. And therefore I think it's a target, not only immune therapy for the cancer itself, but also for the side effects in this ADT group, which is not all prostate cancer patients, of course, but it's a growing group, and they live longer, and they have been somewhat neglected, and I think physical activity fits like a glove for this, and should be, you shouldn't prescribe ADT without physical activity, I would say.
Okay. Thanks a lot. We will continue now, Mats, with the next week.
Thank you.
Okay,
Thank you very much. Thank you.